welcome back to some more POCUS time. So this video, the most appropriate time to watch this is when you've done some scanning and you're getting fairly comfortable with acquiring your views. And now you're starting to think about, how do I use this? Like, where do I find a place for this in my clinical practice? So I guess the first question to ask yourself then, is there a place for it in clinical practice, or is this just a couple of anesthesiologists with a hobby? So there was a fairly good paper in Anesthesia and Analgesia 2020, where they did a review article on the diagnoses and how POCUS was used in patients with intraoperative hypotension. And this was the sort of take-home message for me, that so when you are hypotensive, clearly many patients are hypovolemic. There are some with vasodilatation. There's also this subgroup that have RV or LV failure. Now, if you're just going to do empiric management, that's likely going to look something like give a liter of fluid, give some phenylephrine, maybe start a little phenylephrine infusion, and go from there. But it does mean that this large cohort of patients is going to get probably way too much fluid. And in some of them, this will be enough to really decompensate them and push them over the edge. So clearly POCUS, in my opinion, has a role in making sure that we give patients appropriate treatment. Now, and the patients that are even more unstable, I really liked this paper and I would refer you to it. There's a lot of meat in this paper. The two things that I very much like about it is their kind of stacked approach to acquiring views depending on how much time you have, and also the F structure for findings. So they're looking at, and I would turn this around a little bit, I would go filling and function as my two most important ones, then form, so like what shape and size is the ventricle, and then look for pericardial effusions. So this is an emerge paper. Pericardial effusions probably more common in their practice. As you can see from that last slide, pericardial effusions are kind of low down the bottom for us in terms of causes. But filling, function, form, meaning structure of the heart, and then fluid, with a like a expanding sort of system of acquiring views with priority given to the most important ones at the time that you need it. So for me then, in terms of when I approach my patient, thinking about how I'm going to scan, it really will depend on this. So am I looking at a stable patient and what I call an unstable patient or a pre-arrest patient? Now, my stable patient, you really need to know how to do what for you is a full study at this point. Make sure you do all the detail, the full acquisition of every image, make your pictures beautiful, look at all the detail, have a really good structured approach to getting a full study. For your unstable patients, and I'll define that a little bit more later, I'm going to create a differential in my head as to what I think is going on with this patient, probably, and then I will scan to try and find answers. And then there will be my pre-arrest patient. My pre-arrest patient, I'm going to try and make sure that there's nothing that is a treatable life-threatening pathology. And I'm going to titrate my management based on my echo. So I'll be doing repeated imaging to see if what I'm doing is working. So how do I define those two subgroups? My unstable patient, I would define as somebody with mild hypertension and tachycardia, maybe some hypoxia, maybe some shortness of breath. And this can be at any point during the cardiac cycle, pre-op, intra-op, or post-op. I would develop my differential, as I said, and then I'll do sort of a focus based on what you want to confirm or exclude. Now, the pre-arrest patient is a sicker patient. This is a patient that's rapidly deteriorating with hemodynamics close to incipient cardiac arrest. And I use POCUS in this patient subgroup to guide my resuscitation, as well as to look for treatable life-threatening conditions. And this would be sort of my quick mental list. I want to make sure that I'm not missing some kind of embolic event. In the pregnant patient, this could be amniotic or air. In other patients, there could be air depending on the surgery. It could be a massive thrombotic PE. In a patient that's being immobile or in a cast. Dynamic outflow tract obstruction should always be on your radar. Could be an acute LV or RV dysfunction for other reasons than a PE. hypovolemia. Now, this can be absolute or relative. You can have some blood loss, or you can have anaphylaxis, which will make your heart very, very empty, even though you haven't lost volume as such. Always want to think about pneumothoraces, so add that A and B to your scanning. You will be doing some lung scanning in this acute patient, and tamponade, which for us is lower down, but you will see if there's fluid there. So what does a pre-arrest scan look like for me? Rapidly deteriorating hemodynamics with incipient cardiac arrest. I will start with a short axis. So a short axis looks something like this, and you can get that either from your parasternal or you can get it from a subcostal. That's a bit more of an advanced POCUS, but probably something I would suggest that you try and learn. And we're going to look at our EPs. So is there tamponade? I mean, is there fluid here? No, so no tamponade. Now we're going to look at filling. So is the heart filling? Is it functioning? And what is the form of this heart? Is it big and dilated, or is it really small cavity? My next view would be probably a subcostal. For a spontaneously breathing patient, to look at that IVC. If I can get access to it intraoperatively, that's sometimes hard if they're working on the abdomen. I'd look at the lung as looking at lung slide, so right and left apical views to make sure you don't have a tension in the thorax. Okay, and based on these two views, I would start to exclude or include some of those things in my differential. So what would a massive PE look like? So a massive PE would give you a very small LV, large RV with a D-shaped septum. Severe LV and RV dysfunction, you would see the heart really not coming in, not contracting very well, same for the RV. Hypovolemia, absolute or relative, would give you a very hyperdynamic RV, LV with very little fluid in it and a very collapsed IVC. The massive PE, by the way, and the RV dysfunction here would give you very dilated IVCs. Pneumothorax, we would see on our lung scan, and tamponade, we would see in either of those two scans. The only one that you wouldn't get in these views really is a dynamic outlet tract obstruction. So if you still have really ongoing hypotension that you can't figure out, you will need to get a parasternal long axis for this to look at that anterior mitral leaflet. Okay, so that's the pre-arrest patient in terms of sequence of imaging and looking at diagnostics. So how do I use that as an adjunct to my resuscitation? So I think traditionally for us, your patient go hypotensive in the OR, you open your IV, give some fluid, you add some phenylephrine, maybe add an infusion of it. Sometimes we add an inotrope at our site, probably in help more, and honestly we're concerned about RV dysfunction, but every site's a little bit different. And the contribution of the lungs to hemodynamic collapse would be assessed with auscultation. And if you're lucky, you can get a chest x-ray with that. Often will be delayed. And auscultation, as we know, is a very inaccurate way of assessing lung function. So how does a POCUS-guided resuscitation look? So, well, firstly, we will look at the volume aspect. So here we can really start making some better decisions for our patient. So first we look at, is the volume required? And then, is it safe to give the volume? So we want to confirm the small cavity LV. So if there's a large LV, you don't need to give volume. If you have a very dilated, struggling LV, clearly you don't need volume. You confirm that there's a small cavity LV, but it might still not be safe to give volume because sometimes the small cavity LV is because the RV is struggling to function and is actually not getting blood through to the LV. It's becoming dilated, pushing that septum into the LV. And the LV is now actually limited in filling by the expansion of the RV into its space. So giving that patient fluid actually could make your LV function and your LV filling worse. So how can we look at this part? So exclude the RV dilatation either on your imaging, or if the RV cannot be visualized in a spontaneously breathing patient that you have access to that area, you won't get the IVC. If it's small and collapsing, likely the RV is okay. So if it's big and distended with a small cavity LV, you probably don't want to give fluid. There's something going on with that RV. So if the volume is required, you give more volume and then you repeat this and see what it looks like. You can add precision inotropes based on your function. So whether you need inotropes or whether you need more pressors. And then you can do your lung scanning, which will really definitively tell you whether there's movement of that lung and the potential for pneumothorax, which is a much better exam than a clinical exam for that, to investigate that. Now, please keep in mind that an empty hyperdynamic heart with no obvious cause for volume loss could be because of other reasons. So always keep in the back of your mind anaphylaxis, impending sepsis, or some occult blood loss. And that for me would be my sort of stacked approach to scanning. Once my patient stabilizes, I'll move out of these kind of just urgent scanning views, and I will do more complete study to make sure that there wasn't something else that I missed. I hope you have fun scanning and using this in your clinical practice. Thank you for watching.